Okay, here we go. First ever recorded training on our new Microsoft Teams account or Microsoft account. Okay, this is great. So what I'm going to try to do is talk about what I consider to be the basics of 12-lead interpretation. My goal is to go to this lovely site called Wavemaven. It's my favorite EKG site ever. And then, there's Life in the Fast Lane. There's people out there that explain things way better than I do. But I guess there's a lot of rules you can memorize with 12 leads. I like to take more of a conceptual approach where you're not, do you have to memorize like what the intervals should be, your PR interval, your QT, what QT prolongation is, what a wide QRS complex is? Yeah, you do. So there's that basic stuff. Do you have to memorize what a normal appearing EKG looks like? Yes, you should be familiar, like not necessarily why, but looking at a 12 lead and you can say either this looks normal or this looks abnormal for any reason. I would recommend memorizing what a normal 12 lead looks like. And this is something that I don't think people dedicate enough time to. So we're going to be an attending physician today. Okay. So I'm going to start off by showing a couple of principles here. It's going to start with anatomy. We'll talk about the way electricity goes through the heart. And it may sound a little complex, a little daunting. It may even sound a little bit advanced. But to be truthful, it's not. It's the basics of 12-lead interpretation. So let's look at a normal 12-lead together. 12-lead. Yep, that looks pretty normal. A little bit of artifact. That's okay. Where is it? Sorry. View image. Where are you? There. Okay. This is about what a normal EKG looks like. Of course, there's like the speed, 25 millimeters per second. So the first thing, and this is going to sound like we are going to start out basic, but the first thing is divide this 12 lead in half, left side and a right side. Okay. And I'm going to put this actually onto Paint because this will be helpful. Okay. So let's just get into some basics of math here. Inside one of these big boxes are 5 little dots. 5 boxes inside of the big boxes. Each one of those little boxes, the 5 inside of here, are worth 0.04 seconds apiece. This is stuff you have to memorize. 5 of them together, also known as one big box, which is seen highlighted here, is 0.2 seconds. So 0.04 times 5 is 0.2. So every one of these big boxes is 0.2 seconds, which means 5 of them are 1 second. So if you counted them all through this right here is a 10-second strip. So 1, 2, 3, 4, 5. That's 1 second. 1, 2, 3, 4, 5. That's 2 seconds. Actually, it starts a little bit over here. Anyways, this is a 10-second strip here to here. One of the ways I like to do to look at the rate is to do this sort of like if you had a QRS complex, every single one of these, so that would be 1, 2, 3, that's 300 beats a minute. So what you should do is take 300 and divide it by the number of big boxes you have, and that's your heart rate. So here's an example. If you had 1 every big box, that'd be 300. 300 divided by 2, this is 150. So if you had 1 every 2 boxes, that would be about 150. 1 every 3 boxes, that is 300 divided by 3, that's 100. 4 boxes, 300 divided by 4, 75. 5 boxes, 300 divided by 5 is 60. 6 boxes, 300 divided by 6, that's 50. 300 divided by 7, I don't know, less than 50. So you can kind of get a rough idea just by counting how far away these boxes are, assuming that your rate is regular. And what I like to do is find one that's right on the line. So 1, 2, 3, 4 boxes is 75, 5 boxes is 60. But this is closer to the 75 than it is the 60, right? So this is about 70 beats a minute probably. And I would bet that if I counted, oops, what did I just do? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 times 6 is 72 beats a minute. So anyways, okay, again, I like to divide the heart into 2 parts. This right part is the precordial section, V1 through V6. These are the ones that go around the chest. This part here is the limb and augmented leads. So when you consider the 12 lead axis, I don't ever memorize this stuff. I just kind of understand the concept. If I ever had to like look it up, then I could make obviously a lot of sense of it. So I look things up to be like, yes, that's what this equals. That's fine. But I don't actually memorize this on a day-to-day basis because I don't have the brain space for it. So let's see, let's find one other picture here. Oh, here's a good one. That's a good one. These are all good ones. So things like this, right? Yeah. So imagine like this here. Let's do this. Copy image. Paste. Well, it's kind of blurry. That's okay. Left axis deviation, normal axis, right axis deviation, extreme axis. And then what's the other one? Yeah, this is a good one. So like these are the same, if you can kind of imagine them. Why is this? Oh man, I don't know how to use paint. That's okay. Anyways, so you don't have to memorize that 1 goes here, 2 goes here, AVF, 3, whatever, negative 150. People are like, oh my gosh, that's so intimidating. I can't remember it. It's really not that bad. So the way that I like to remember it is, oh, I wish that was a better picture. Let's see. There we go. So the electrical impulses of the heart start here in the sinoatrial node, travels down through the atria into the atrioventricular node, AV node, somewhere in the middle, and then down the septum, and then up the outer parts of the ventricles, and then that ejects blood, puchow, out the atria. Puchow, like that. So if you can see my cursor, on average, every single heartbeat kind of goes like this. It starts here, it pauses for a second at the AV node, and then it goes down to the ventricles, then kind of swings back up, and then it trickles down here. This part right here has the most amount of muscle and tissue in the heart, so the most amount of electrical impulse comes from this area. This is called the point of maximal impulse. So it goes gunk gunk, gunk gunk, gunk gunk, like that, boom boom. And so if you were to say, on average, what direction is the electrical current favoring in the heart? It's favoring the SA node to the AV node. Of course, it goes this way and it goes this way, but those average and meet in the middle, right? All of this electricity is counteracted by all of this electricity. So the average vector of the electrical impulses in the heart go this way, towards the left ventricle, somewhere around here. Now you have to say which lead in the heart most closely falls in line with this. Well, it's lead 2. Lead 2 is negative up here, and this is where the negative and the positives, the polarity come into play. I also don't remember this is negative, this one's positive. I mean, I have an idea, But in this particular lead, this one up here is negative on the right shoulder, and this one down in the belly or whatever, the bottom part, is positive. So electricity is going from negative to positive. When electricity goes from negative to positive, that causes a, why is it doing that? Normal 12 lead. All right. When electricity travels from a negative electrode to a positive electrode, that shows up as a positive deflection compared to the isoelectric line. Now, take this lead, for example, AVR. It's kind of the exact opposite of lead 2, right? Electricity is going almost entirely away from it. It's going away from this lead. AVR is a positive lead. So if it's going away from a positive lead, then that is going to show up as a negative deflection. Since almost the entire electrical vector is going away from AVR, the entire lead is going to show up negative on the tracing. This one right here, it's still generally in the positive direction, but just not as positive as lead 2. That's why lead 2 is the monitoring lead, because it has the best representation of the atrial activity and the ventricular activity in terms of the left side of the EKG. Notice how the amplitude of the QRS complex gets smaller the more you get away from where the average vector of electricity is. Same thing with here, it gets smaller, okay? This is an important concept. This is called the axis of the heart. And the axis of the heart should point somewhere towards lead 2, somewhere between 1 and 2. If it goes this way, it's deviating to the left. If it goes this way, it's deviating to the right. Why is it deviating to the left and to the right? Disease, structural heart abnormality. Maybe the heart is even swapped in, like, dextrocardia or flipped over. Heart failure, MI, bundle branch blocks. I mean, that is beyond the scope of just this introductory training. But every heart has an axis, and it points, the majority of it points towards this way. If the electricity shifts this way, it's deviating to the right, the patient's right atria, right ventricle. If it's deviating this way, it's deviating towards the left atria. You don't have to memorize why it deviates. There's a lot of reasons, and it's too complex and involved to explain in this one training. However, this concept, very important, and I think it should be taught in the basics of EKG mastery, or even learning EKGs. So this left part right here is the augmented. This is where this axis comes into play. The right side of the heart, which I have covered up, V1 through V2, this is the left ventricle version of the axis. This is called the R wave progression side. So imagine that V1 through V6 are all positive leads, okay? And the point of maximal impulse is somewhere down here where the majority of the cardiac tissue is, right? More electricity occurs where there's more tissue, just like, big muscle groups use more energy in your body. Well, big heart groups, aka the left ventricle, uses more electricity, which means when there's more electricity, these QRS complexes are bigger. So the point of this is to say that if you just kind of imagine V1 right around here, V2 right around here, V3, V4, V5, V6, V1 and V2 are up here, right? For the majority of these two leads, the electricity is going away from them, right? Because it's coming down here. Between V3 and V4, again, this depends on where you place your leads. If you place your leads in messed up places or wrong places, then this is going to look bizarre. So you have to put your leads exactly correct. Like this is a basic thing that people don't do. If your leads are not within 95% of where they should be in terms of closeness, then your EKG is wrong. Can't believe it. Like you have to put your EKG leads exactly where they're supposed to go. You have to also not move the leads once you've placed them, unless they're incorrect, of course. And if they are, disregard all the previous EKGs you took. And you should also keep the patient sitting either flat or 30 degrees, obviously if their condition can tolerate it, but keep the patient in the same position. If they're sitting up and then laying down, EKG is going to look different. How can you identify trends if you induce changes by moving the leads, placing them wrong, or moving the patient up and down? You can't identify trends. You are externally inputting changes to the EKG, and then you're trying to identify, is your EKG changing, i.e., are there dynamic EKG changes, i.e., is the patient's cardiac condition getting worse? You can't with certainty say that it is or isn't if you're moving the leads, if the leads are wrong, or if you're changing the patient's position. So put the leads 100% correctly where they're supposed to go according to the textbook definition. And then put the patient in the position that they're supposed to go according to the textbook position, which is like flat to 30 degrees-ish, right? And then don't move the patient and don't move the electrodes when you take serial EKGs. That is a basic concept that people, in my opinion, negate all the time. I see V1 and V2 all the way up at like the collarbones, okay? So if you put them up here, what's the majority of the electricity doing? It's going like all the way away, so much away that you might even get inverted P waves and inverted or biphasic T waves. And you might be like, oh my gosh, the P waves are inverted. This is an abnormal EKG. Yeah, no shit. You put the EKG sticker so high that everything is negative when you're referenced because the electricity is moving away. It's so negative that even your P wave is inverted. You induce that by putting the leads too high. Put the leads on correctly. Okay. So that's a basic concept, and all has to do with electrical access. So going back to V1 through V6, sorry. If V1 and V2 are like here, of course, I'm simplifying this for the sake of a visual cue. V1, V2, primarily the electricity is going away, which means those leads are going to be primarily negative because V1 through V6 are all positive leads. If it's going away from a positive lead, it's a negative deflection. If it's going towards a positive lead, it's a positive deflection. If V3 and V4 are somewhere in the middle, that means that half of the electricity is going towards it, and then half of it is going away from it, right? What does that mean? That means half of the lead is going to be up, and half of the lead is going to be down, somewhere between V3 and V4. That's called the R wave transition point, right? That's an R wave. R wave is transitioning, and somewhere around V3 to V4, it should be 50-50. Because if you imagine V3, V4 being right here, half the electricity is going towards it, then half the electricity is going away from it. Now, as you get down towards V5, V6, over here, almost all the electricity is going towards it because the electricity starts in the SA node, goes to the AV node, comes down to the left ventricle, then dissipates as it goes up. So all the electricity is coming towards it. If all the electricity is coming towards it, towards a positive lead, that means it's all a positive tracing. Kablam. See that? Positive. So what's an example of where V6 would be entirely negative? What if your electrical impulse originated here and then went upward or away from V6? If it's going away from a positive lead, that's a negative deflection on the EKG tracing. When does electricity go from here up? VTach or ventricular beats. Yeah, that's bad. So if your V1 through V6 or your precordial leads are entirely reversed, i.e. this is up, this is up, this is still 50-50 maybe, or just abruptly changes, and this is down, 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 that could be VTach, especially if your QRS complex is wide, because this indicates time. The x-axis is time on an EKG. So every time I look at an EKG, I say, what is the precordial R wave transition, i.e. the left ventricle axis, and then what is the axis of the heart? Is it going from here to here like it's supposed to, or is it bending this way or bending this way because of pathology, disease, or structural heart abnormalities? That's the question. So when I analyze an EKG, I don't just analyze the rate. It's this easy. So to summarize, here are my basics. What is the rate? In reference to what I memorize as a normal EKG, does something look different? So look at thousands of EKGs and just get a feel for what normal is. So I look at an EKG and the very first thing I say is, yes, this looks kind of normal, or it looks kind of not normal, or very not normal. And then I say, what's the rate? How many of these boxes or how many of these beats are in how many complexes are in a 10-second strip. So the total amount times 6. Or you can do the box method, 300, 150, 100, 75, somewhere a little bit less than 75. Is there a P wave for every Q or S complex? And then a T wave. So I'm looking at the CKG tracing. Somebody says, hey, Mickey, can you take a look at the CKG? I'm like, okay, looks pretty normal. And then I'm like, okay, P cure ST, P cure ST, P cure ST, P cure ST, P cure, and I just do that for the whole EKG. All right, this is a normal sinus rhythm. What's the rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 times 6 is 72, about 72. Normal sinus rhythm. I do that with every single EKG. And then I do the axis on every single EKG as a basic principle. So I would recommend doing that. Remember, I said that it switches somewhere around V3, V4. Half the electricity is going towards it, then half away. So it should be 50-50. Around here, it should be primarily negative, negative, 50-50, positive, positive, positive. So in this EKG, the R wave transition is normal. Now let's look at the axis on this side. So let's look at lead 1 and AVF, which are the upper and lower limits of this side part of the EKG. There's no lead higher than lead 1. And there's no lead lower than AVF. High lateral, low inferior. This is the upper and lower limit of the heart. So nothing extends beyond this, and nothing extends beyond this. So I like to look at 1 and AVF as my rule maker. Okay, let's decide why. Let's look at lead 1. Yeah, could it go up to AVL? I guess, but I mean, ordinarily the axis is between here and here because it's going from SA node to AV down to the ventricles, then it dissipates as it goes up. So somewhere in here is a normal axis. So we just take the 90 degrees left and right of that normal axis, and we look at what it looks like on the 12 lead. So if the electricity is going from here down and down, it's primarily going in the same direction as lead 1. Not as well as in lead 2. Again, that's why lead 2 is the monitoring, is the internet, is the standard accepted monitoring lead. But it's generally going positive. So lead 1 should generally be positive because it's, I mean, yeah, is it exactly in line with this? No, it's not, but it's not going backwards like AVR is. Backwards, AVR is opposite where the electricity vector goes. So lead 1 is going kind of in the same direction as the vector. Similarly, lead AVF is going kind of in the same vector. Not quite as good as lead 2, but kind of in the same vector. The point of this is that lead AVF should be positive, and lead 1 should be positive as well. What happens if lead 1 is negative? That means instead of going this way towards lead 1, it's going this way, away from lead 1. What part of the heart is this? This is the right part of the heart. So if it's going away from lead 1, still kind of towards AVF, because it's still kind of going down, but away from lead 1 would be negative. That is right axis deviation. Similarly, if it's going, let's say it's going away from lead AVF here, away, it would have to bend this way. This is the left part of the heart, left atria. This is left axis deviation. So lead AVF would be negative. So let's do this little thumbs up thing. If you imagine a thumb up, put your thumb up. Put your left thumb right here. And then put your right thumb here. If you have 2 thumbs up, you have a normal axis. Now let's say you have right axis deviation. Lead 1, the axis is bending away from it. So lead 1 is going to be negative. So put your thumb here and imagine that this is negative. That's a thumb down. And then put your thumb here again. This one's still positive because it's going towards AVF. So if you have a thumb down on lead 1 and a thumb up on AVF, the way that I memorize this is whatever thumb is up, that's the axis deviation. So if your right thumb is up, that's right axis deviation. If your left thumb is up, that's left axis deviation. If both of your thumbs are down, that's bad news bears, and that's extreme axis deviation, which is over here. That means pretty much your heart is going from this, instead of going from here down, the electricity is going from here up. It's totally opposite. It's 180 degrees. AVR would probably be positive if that was happening. So if you had a thumbs down here, a thumbs down here, and AVR was totally positive, basically all three of these are 100% or 180 from what they are here, that's extreme axis deviation. You see extreme axis deviation in like really, really diseased hearts, maybe some MIs, and then like idioventricular or VTAC type rhythms. Okay, so what I like to do is apply those basic principles to every single EKG that I look at. So what I'm going to do in this series, I hope maybe I could do like one a week. I'm going to remind everybody of those rules: thumb up, thumb down, axis, rate, general normal appearing EKG, and then we're going to apply those to every single EKG we analyze on WaveMaven. And we're also going to get a little detailed because a lot of people, if you're basic at EKGs, just stop there. Just keep practicing those principles. What is the rate? Does it look normal compared to what I think is a normal EKG? Get out this Einthoven's triangle and practice like doing your own axis interpretation. Do a thumb up, a thumb down. So is there a P wave with every QRS? Is there a QRS wave that, or QRS complex that kind of looks normal? Is there a T wave associated with it for the whole EKG? Are the beats really fast or really slow? Is the axis normal? Is the R wave transition normal? Every single EKG should do that. If your leads are placed wrong, redo it. If the patient's sitting up too high or sitting down weird, I don't know, like on their side, for example, redo it. If there's a lot of artifact, redo it. If the patient's breathing really fast and you can't get a good tracing, I don't know what to tell you. I mean, sometimes you just can't get a good tracing, but if you can get a good tracing, get a good tracing and keep the patient in the same position. Don't move your electrodes. Like, there's nothing better than a patient to shave, in my opinion, because I can make shave marks exactly where the EKGs could go. That way, all future EKGs will probably be placed correctly. So, all right, let's get into it. And every single one of these I'm going to do those 4 or 5 basic rules that I just said. And then I'm going to get into the actual nitty gritty of some EKG interpretation. What I like to do on WaveMaven is cover up the answers, which I will do, not look at any of the context of the patient and see if I can see what's going on by just looking at the EKG. This is, some of these cases, very difficult to do. So I could get it wrong. And then it's like, oh, Mickey's telling me wrong information on this. He's supposed to be really smart or whatever. I don't know. So we're just going to go to a random number without looking. And I would like to go to the 4-star ones. That's 3 stars, covering up, 3 stars, covering it up, 3 stars, 4 stars, zoomable, ka-chow. So we're going to look at just the EKG, see what we can decide about it, and then go back to this and look at the clinical context of the patient and what's going on. And every single time we do this, we are going to do those rules that I just talked about. So looking at this EKG, does it look normal? No, it does not. This looks normal. This does not look like this. Okay. For a lot of reasons. This is wide. This is pointing down here. It should be pointing up. That's pointing down there. It should be pointing up. There's weird notches in places you don't expect to see it. This interval is supposed to be no longer than 0.2 seconds, and it is. There's a first degree AV block, whatever. The axis is weird. Okay, so let's do our rules. Is there a P wave? Yep, ka-chow, ka-chow. Let's look at lead 2. It's the monitoring lead, right? There's one, 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 there's one. Yep, this is a sinus rhythm. What's the speed of it? 1 box is 300, 2 boxes is 150, 3 boxes is 300, 4 boxes is 75. So this rate is between 175, closer to 75. It might be about 80. Let's check. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 times 6 is 84. So this is a normal sinus rhythm, and it excuse me, and it looks weird. Now let's look at the axis. Thumb up, thumb midway. So it's not thumb up, thumb down. So this would be more of a left axis because your left thumb, but not totally left axis. So this axis is weird. And then let's look at this right here. This is pointing down, 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 down. There's no R wave transition. This is absent R wave progression. This is abnormal. So by the time the beat gets down here to V5, V6, it's still going away. If all the beats go away, I start thinking VTach. So right away, this is an abnormal EKG. It's normal sinus. The QRS complexes are wide. The PR interval is prolonged. The T waves look kind of big, and then the QRS complexes are kind of deep, especially here. So who knows if there's some sort of like LVH or heart failure criteria met. I don't memorize those rules either. There's an R prime here, which is kind of abnormal. There's a Q wave here, and there's a Q wave here. So this is the same area of the heart, one in AVL or the high lateral leads, and there's Q waves there. So that could indicate some sort of past MI. And it also looks like there might be some ST elevation in lead AVL, although the baseline is trending up. If I could take an EKG somehow with this getting better, I would probably retake the EKG. This is going down. This might be because of breathing or the patient's moving or something, but it looks like it's been resolved by the time it gets here. There's this weird like notching pattern, which you can see sometimes with the Barency. And then, you know, if you were to ask, is this VTach because it's wide and it goes in the opposite direction? I don't know. That seems unlikely. You know why? Because every single PR interval is the exact same length. So is it likely or impossible that the atrial rate is 84 and the ventricular rate is 84 at exactly this moment where it looks normal sinus? No, that's not likely at all. So it's probably not VTach. But it does look wide. There's, I mean, I don't know. Looking at the isoelectric line, which goes like this, there does look like there might be some ST elevation here. And kind of here as well. But there's I mean, that looks like ST elevation, but it doesn't look like there's as much here. I'm not sure. There are T-wave inversions here. And this ST elevation that you see here and the size of the T-wave does not seem disproportionate compared to the QRS complex depth. If this QRS complex was a little bitty, I might say this meets STEMI criteria, but it doesn't really. Boy, I don't know. It does look like there's some trace ST depression in lead 2. So if there's some ST depression or ischemia or reciprocal thing here, and then it looks like there might be some ST elevation here, could this be some sort of like high lateral left-sided MI? Yeah, could be. Could there be some sort of electrolyte abnormality? I don't know. There's huge Q waves here. This could also be a residual 12 lead. This could be like the patient just has these abnormalities at baseline. So a previous EKG would be very helpful in this incident or this occurrence here. Boy, I don't really know what else to say about it. Nothing else really jumps out to me. There's this notching here, so there's obviously this like bundle branch block. There's this left bundle branch block. So the left bundle branch block, you can apply this thing called Sgarbossa criteria to see if your ST elevation is excessive or not. I will say the fact that the QRS complex is primarily up here and there's ST elevation, with the bundle branch block, they should be opposite, right? You should have ST depression compared to where the prominent, if there's a strain pattern with the bundle branch block. If your QRS complex goes up and you were to have a strain pattern, you would see ST depression. If your QRS complex went down like this, you would expect to see a little bit of ST elevation, which is normal for a bundle branch block. And if it's excessive, i.e. it meets Sgarbossa criteria, then you can say it's a STEMI equivalent. So this might be a resolving left-sided, like lateral type MI. Like what is this high lateral? I don't know, maybe the circumflex or something like that. But I have no idea. There does look like there's biphasic P waves here, which is interesting. So there might be some sort of atrial enlargement or some sort of structural intraventricular conduction delay that's causing the left side of the heart to operate a little bit differently than the right side of the heart, and it's showing up as these notched P waves, and then a wide QRS complex that points down. So it's like a left bundle branch block-esque looking thing. I don't know. Could this be some weird sort of like junctional tachycardia? I don't think so, because there's P waves and they look for the most part normal. But let's see. I could be totally wrong, and that's okay, because we are being brave, and we are looking at all of these without any clinical context. Pure EKG diagnostics, baby. All right, let's see. Elderly male with congestive heart failure with sustained VTAC. What type of structural heart disease does this indicate? Oh boy. You know, there is, now that I know he's older and has structural heart disease, the likelihood of having like an outflow tract tachycardia increases. There's absolutely no transition of the R wave. So sometimes when it's like a left ventricular outflow tract tachycardia, there is a transition that occurs around V2. I don't know. This is a guess. This is a toughie. Oh boy. There's a P wave with every QRS complex, so I don't really understand why they're calling this VTAC. Interesting. Not impossible that there happens to be P wave with every single QRS complex. Maybe the VTAC is the exact same rate as the atrial rhythm, and they're just aligned with each other. We did talk about that earlier. I don't know. I'm gonna guess like some sort of hypertrophic cardiac cardiomyopathy of whatever, constrictive obstructive cardiomyopathy, whatever that's called. Slash, like maybe it's some sort of right ventricular outflow tract tachycardia. That's gonna be my guess. I have no idea what else to say, because there is slight axis deviation, delayed R wave progression. There's a left bundle branch looking EKG. And like I said, the idea of this is to not get into why I'm saying this. I could be totally wrong. The idea of this is to apply the basics to every single EKG we look at. So if you're new at this, you apply the basics with me. And if you're good at this, then maybe we're on the same or similar frequency, or maybe we're expanding upon each other's ideas. And then you get some actual EKG practice at the advanced level. So that's the point of these. Let's see. It looks like just another case of sinus rhythm with left bundle branch block. However, if you look closely, you'll note prominent Q waves in leads 1 AVL. We did see that. I guess in V6. I didn't really notice them in V6. Huh. Okay. In the lateral and inferior leads with left bundle branch block are strongly suggestive of underlying cardiac prior myocardial infarction, and we know that. The notching of the ascending limb of the S wave in V4 is also consistent with the underlying scarring or MI with the left bundle branch tuck pattern. Cabrera sign. That's the first time I've ever heard of that term. Yeah, that notching is strange. Yep. There is a prolonged PR, about 240 seconds. We did talk about that. With left atrial abnormality, we did say that there is some notched P waves here. So there's a difference in the left and the right side of the atrial electrical. In concert with the left bundle branch block, the finding of, what does LAA stand for? Left something aneurysm? Huh. Left atrial aneurysm, maybe, is strong evidence for left ventricular hypertrophy. We did talk about that. The patient had congestive heart failure secondary to prior MIs with severe left ventricular systolic and diastolic dysfunction, ischemic cardiomyopathy. He also had sustained monomorphic VTAC tachycardia due to ventricular scarring and was referred to the cardiac electrophysiology suite. Honestly, I don't see, this doesn't look like VTAC to me. Oh, that's tough. I'll take the loss. Okay, let's do 2 more for some practice, because I don't want to get too far. How long have we been recording for? 39 minutes? We can maybe hit 3 more. Next case. 3 stars. We want the 4 stars. Yes, we do. We're not looking. We're not looking. We're being up. There we go. We're being honest, right? Oh, interesting. Okay. All right, let's apply the basic rules. Does this look normal? No, it does not. Is there a P wave for every QRS complex? Yeah. P, 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 P. Could this be atrially paced? Is that what that represents? Maybe. Atrial pace, intermittent atrial pace. Huh. Could be. Those do look like pacer spikes, huh? Interesting. And then there's this PR depression. Okay, anyways, going back. Does this look normal? No, it does not. Is there P for every QRS? Yes. Is it paced? I don't know, maybe. Does the QRS look wide? Nope, looks narrow. So this is a sinus rhythm. What's the rate? Let's do our little rule here. There's one that starts right on the line. That's what I like doing. Find one that starts right on the solid line. That's 300, 150, 100. So it's about 100 beats a minute. A little bit fast. And then what's our other rule? The axis. Pointing up, pointing up. Thumb up, 2 thumbs up, you're good to go. That's a normal axis. Reference this if you want to. Always reference this. Don't memorize it because it takes up brain space, but just keep memorizing it, referencing it so you can be like, yes, it does go from here to here. So kind of is positive. It's kind of in that direction. It's kind of positive in this direction. Therefore, the QRS complex in AVF and the QRS complex in lead 1 should be normal, assuming the electricity is moving from where it's supposed to where it's supposed to. In the absence of structural heart disease, some sort of cardiomyopathy, ischemia, or MI, or some sort of anatomical abnormality that the patient has, like a flipped or heart. A lot of patients with lung disease that have a change in the chest, the thoracic cavity size and shape because of lung disease, like hyperinflated lungs, you actually the heart can rotate, so that will change the axis. So patients with really bad lung disease can have EKG abnormalities that are, they're there forever because of the underlying pulmonary disease. If you have structural heart disease caused by respiratory problem as its primary cause, that condition is called cor pulmonale, and there's EKG abnormalities for that. All right, so circling back. And then is our R wave progression down? Is it normal? Is it primarily down, 50-50-ish? And then up, up, up? Yes, it is. So this is let's summarize this. Does this look abnormal? Yes. Is it a normal rate? It's 60 to 100-ish, but it's on the fast side. Is there a P for every QRS complex? And do all the complexes look about the same? Yep. Is the QRS complex narrow or wide? It's narrow. And then our access and our precordial R wave transitions are both normal. That's the basic of every single EKG interpretation at its onset. Now, let's get a little bit analytical here, shall we? Okay. What do we see? It looks at first glance like there might be some ST elevation. And it just looks like those are pacer spikes. Could it be artifact? Yeah, I don't know, but they look like little teeny pacer spikes. That looks like ST elevation, but I don't know. There's also some PR depression. See, like this is the isoelectric line right here. Right before the P wave, after the ST segment, right before the P wave, that's considered your isoelectric line. So let's go to a lead where this looks kind of normal. That's the P wave. So like somewhere around here is probably the isoelectric line. So is this actually ST elevation? I mean, maybe a little bit, but where is their ST elevation? It's here, 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 here. That looks like it might be ST depression, but there's artifact. I can't tell. ST depression. It looks like there's a little bit here, a little bit here, a little bit here, a little bit here, a little bit here. There's ST elevation everywhere. So this person is either having an entire, like needs a cabbage, or there's something else that's causing like ST elevation everywhere, like a slight J point elevation. And then also it looks like there's PR depression. I could be totally off here, but this looks like it's benign early repolarization-ish, but it could also be, since there's PR depression, it could be the, oh boy, what do you call it there? Not rheumatic disease, pericarditis. Yep. Pericarditis. Oh man, I don't know. These T-waves here do look kind of big though. Not excessively big. This ST elevation right here does look concerning. I will admit that. That looks like ST elevation. Even with the PR depression, that looks like ST elevation. Huh. I would try to get a cleaner EKG tracing, to be honest with you. And is there really ST elevation everywhere? But the flat appearance of, excuse me, the flat appearance of this is concerning. I don't like flat ST segments. They should smiley face and cove up typically. And there is there's like global T wave abnormalities, like they're flat, 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 especially in this lateral section. Now it's just this whole EKG looks weird and it's fast. AVR is negative like it should be. This looks kind of excessive compared to the size of this. I don't know. This looks like an intermittently paced, atrial paced rhythm. But it's interesting because even where I do see these like little pacer like looking things, they might not be pacer spikes. It could just be, but I don't know, they kind of look like it. Interesting. All right. My first gut instinct, just based off this, tells me that there is some atrial pacing activity. There is sort of global ST elevation, J point elevation, and PR depression. So either this guy has like gonna need a cabbage, or girl, whatever it is, or it's like pericarditis or something like that. I don't really see. There are some QAs here, and trace there. So there are some QAs. There's some inferior QAs. So that's not normal, obviously. But this coved PR depression part right here, it's not a delta wave, and then like it's not dig dips happen at the end of the QRS complex, so it's not digitalis toxicity, and there's no egregious axis deviation or R wave transition problem, and AVR is normal. So, and it doesn't look like there's huge T waves everywhere. So, it's like electrolyte speaking, it's probably not an issue. Boy, I don't know. All right, let's get in. Let's see what's wrong. 29-year-old male with chest pain. It's pericarditis. Oh, with the fusion of possible tamponade. Interesting. There's diffuse ST elevation with slight PR deviation. We do see that. In addition, note the resting sinus tachycardia and borderline low voltage. Okay, that explains that. Yep. Tachycardia at a resting patient is not normal. And then the low voltage, that could be because of fluid collecting around the heart, thereby dulling the magnitude of the electrical amplitude you see. Coupled with hemodynamic compromise. Patient went to the OR for pericardial drainage procedure. But it doesn't, how do we know that there's hemodynamic compromise? It doesn't tell us. Anyways, that's not really a 4-star one. That's kind of easy. Okay, let's do 1 to 2 more. Let's see if we can get 2. All right, let's look for the next one. Let's 2-star, 4-star, ka-chow. All right, we didn't look. We're being honorable here. That's what's important. All right, let's apply the basic rules. P waves, don't see them. QRS complex looks kind of narrow. Maybe a little wide. Is there a P for every QRS? Nope. QRS. So, sorry, let's backtrack. Does this look normal? No, it does not. P waves, don't see them. QRS, looks kind of normal. How many beats? Where's one that starts right on the line? Right here. 300, 150, 100, 75, 60. What's 300 divided by 7? 280 divided by 7 would be 40. This is like 30 beats a minute, maybe 30 something. All right, let's do the times 6 rule. 1, 2, 3, 4, 5, 6, 7, 8 times 6, 48. Okay. So slow. And then let's do our axis. Thumb up for lead 1, thumb down for AVF. Again, reference this if you want a refresher. Thumb up, thumb down. Which one's pointing up? The left side's pointing up. That's left axis deviation. That's your little cheat rule. And then if you ever wanted to understand the concept, you'd come back to this. left axis deviation. Is the R wave transition normal? Well, it's down like it should be. It starts to go up. It's almost 50-50 here. But then something weird happens here where it looks like there's actually less transition here than here, and then there's more transition again. And it doesn't fully transition upward. So that is very strange. So R wave progression is delayed at best. So delayed R wave transition or progression. Q waves? Don't really see any. Without P wave activity, it's difficult to say if this is an aberrancy due to like some sort of hemiblock. Well, this is slow. Sometimes it's hard to tell if the R to R is the same with slow beats. Let's see, 1, 2, 3, 4, 5, 6. That's just over 6 boxes. 1, 2, 3, 4, 5, 6. That one's 7 boxes. Maybe this is a slow AFib. 1, 2, 3, 4, 5, 6. It's like 6.5 boxes. 1, 2, 3, 4, 5, 6. It's close. It might be kind of regular actually. 1, 2, 3, 4, 5, 6. 6.5 boxes. 1, 2, 3, 4, 5, 6. 6.5. Okay, so this is actually pretty regular. Huh. Well then. It's not super wide. This could be some sort of junctional rhythm, I suppose. And it looks like there's U waves after the T wave. Ooh, U waves, no P waves in a weird looking QRS. This could be like a hypocalcemia, prolonged QT. I'm going to say that this is an electrolyte disturbance. Oh yeah, this is a calcium issue. Oh, look at that U wave. I suppose, well, I don't see any Osborne waves. I was going to say it always could be hypothermia. Never sleep on hypothermia. Huh. There's T wave inversion here and here. So there's T wave inversions. I don't know. I'm going to guess that this is an electrolyte issue. Let's see. 86-year-old man with a slow pulse and fatigue. What is the atrial mechanism? What is the likely AV relationship? What is pacing the ventricles? Whoa. I did not expect that. I don't see any atrial activity. I don't see any superimposed P waves inside of the QRS complexes. There's no notching. Huh. Is this slurred? Maybe a little bit. Is this a digoxin issue? Whoa. Maybe the patient takes digoxin and they have digoxin toxicity. But there's no dig dips. Maybe you don't have to see the dig dips. I'm going to say this patient has massive electrolyte disturbance to be causing bradycardia. Maybe not massive, but definitely moderate. Moderate to severe electrolyte abnormality would be my guess. And because there's no, like the P wave is, what's pacing this? Well, it's not super wide. So this is junctionally paced rhythm, probably. High junctional, because this isn't super wide. So something is maintaining, like the pacemaker of the heart is coming from the junction, I do believe. And it's maintaining somewhat of a normal rate. So it would be unlikely that a rate of almost 50 would be causing severe hemodynamic compromise. So I would say this is coming up. This is probably high in the junction instead of coming down in like the septum, Well, I'm going to say this patient has a calcium issue. Ka-chow. Man, I knew it. It looks so regular, though. Regularized ventricular response. Oh. Complete heart block with a junctional escape mechanism. Okay, the junctional escape mechanism is what's normal. However, slight variability is noted in the ventricular response, and intermittent anterograde conduction cannot be excluded. The QRS complex is 120 milliseconds, shows an intraventricular conduction delay with left axis deviation. We said that. And probable left ventricular hypertrophy. In addition, there's a QT U wave prolongation, nonspecific ST-T changes. Etiologic differential diagnoses include intrinsic conduction disease with a need to rule out drug toxicity or metabolic factors. The long QT here is against digitalis. So the sole factor, because digitalis shortens the QT. We did talk about digitalis toxicity. Hypokalemia, not a cause of bradycardia usually, or relevant drug effects such as sotalol or amiodarone should be excluded. Treatment. If no reversible causes are found, the patient will likely require an implanted pacemaker, as well as anticoagulation. Oh, man. A commonly posed question is whether left ventricular hypertrophy can be diagnosed by voltage criteria alone in lead AVL. Well, I guess that is kind of a tall R wave, but it's bigger than 10. In the presence of last axis deviation consistent with a left anterior fascicular block. I don't know. This is a little bit above my pay grade, to be honest with you. The issue is compounded by the fact that some of the widely used voltage criteria, LVH, were derived in many cases before left anterior fascicular blocks were defined. And the two may coexist, which is likely what is occurring here. In favor of this case of LVH, not just the left anterior fascicular block, is the very tall R wave in AVL. Yeah, it is pretty tall. The widening QRS is 120, and the STAT changes, and the atrial fibrillation. You know, that was tough. These are very, the slower it is, the harder it is to tell if it's AFib, really. So, and then also, like, you know, the faster it is. AFib's, you know, 70 to like 140, you can tell pretty reliably that it's AFib. It gets a little bit more tricky if it's faster or slower than that. Echocardiogram. Yeah. Boy, that's tough. I don't really think I botched it, but I don't know. I thought AFib originally. It is slow. We did talk about like hypothermia, metabolic, toxic stuff. We did talk about digitalis, how there's no like dip at the end of the QRS complex, which because there's that dip that prolongs the QRS complex, that shortens the QT interval. And here it looks like there's a prolonged QT and a U wave, which I don't typically see in digitalis toxicity. All right. Well, that one was a indifferent one. I don't think we really nailed it, but I think we did find some key components of the EKGs. All right, let's try another one. Ooh, that was a 4-star. Zoomable. Let's see. What's our time at? Probably about an hour. Whoa. Whoa. Oops. Okay. Alrighty. Does this look normal? No. Are there P waves for the every QRS complex? Honestly, I don't see any. There's a little bit of artifact. Does the QRS complex look wide? No, looks okay. So that's something you have to memorize. You have to memorize the intervals, the PR interval, the QT interval, the QRS complex. What I know what Q wave sizes, all that stuff. You do have to memorize those. You also have to memorize what a normal EKG looks like. And then everything else is conceptual based. Okay, so going back to our rules. P waves, I don't know. That might be a P wave, but I don't think so. Is this regular or irregular? That's a pretty basic thing to do. I forgot to mention that. This looks irregular. And then let's talk about the axis. Lead 1, thumb down. Lead AVF, thumb up. Which thumbs up? The right is thumbs up. What is right? Right axis deviation. So right axis deviation, let's talk about the precordial transition. There's a big R wave right here. That should not be that big, especially compared to this. And then it transitions almost, it's an early transition, but it never really, it starts transitioning early, but then it also doesn't finish. So this is a messed up R wave transition, but I don't know how to define it. Like this should be more downward. This should be almost entirely downward. This should be about 50-50, but this is 50-50. This is 50-50. What causes excessive gain? Left ventricular hypertrophy. So this is a pretty recognizable, like this is a pretty egregious example of left ventricular hypertrophy. So what does this look like total? Let's see what the rate is. We're not going to use the box-to-box method because this is irregular. So we're going to count them all up and multiply by 6. There probably is one right here. So it might be a little fast. It might be a little faster than what I'm going to estimate here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, maybe 17. So this is 96 to about 102 beats a minute. Kind of fast. In terms of AFib, though, in my opinion, 100 is a relatively rate-controlled rhythm. It's like faster than 120 is really when you kind of start getting into uncontrolled AFib, and certainly faster than 140 to 150, you would start considering primary versus secondary causes, and then you might have to consider providing rate control at some point, especially if there's low blood pressure that can't be attributed to something like sepsis. Yeah, so, all right, circling back, I don't see any P waves. It looks irregular. There's about 100 to 105 beats a minute. Overall, looks abnormal. We said thumb down, thumb up. Which one's pointing up? The right one, right axis deviation. The precordial transition looks very strange, and it doesn't transition like it should. So, but it's not quite delayed, but it's also like kind of early. Very strange. But either way, you could say that the R wave transition is abnormal. Why is it abnormal? Well, the QRS complexes look really, really high. I think that's probably due to left ventricular hypertrophy. Yes, I do. There also could be some lead placement issues here because like V1 especially doesn't really make any sense why it's so small. Okay, there is T-wave inversion, T-wave inversion, T-wave inversion. So there's T-wave inversion in the inferior part of the heart. There's also ST depression in the lateral part of the heart. With this ST depression here and T-wave invergence here, this is like a kind of a strain-ish pattern. And with an R wave and an S wave, this might actually represent some sort of partial, like left-ish, not a left bundle branch block. I don't think it quite meets the criteria for that. It's close. Maybe it does. There are these quote unquote bunny ears, which I don't like to use terms like that because it doesn't really do any good to memorize terms. It does good to memorize the concept or to understand the concept, right? Not just memorizing rules, because you forget rules when you have to memorize them. Conceptual knowledge is forever. Yes, it is. There's some ST elevation in lead AVR. So this definitely looks kind of ischemic, huh? So a little bit ischemic. I don't know. AFib with borderline RVR, some sort of non-specific conduction delay, maybe some sort of like hemiblock or posterior fascicle type of thing. ST changes kind of like in non-specific areas. There's this like strain pattern, which you can see with LVH and bundle branch blocks, but this doesn't really look like a full bundle branch block to me. I would say the strain pattern is more due to the size of the left ventricle, which is why we see this LVH. Like these are bleeding over each other. When you see that, you could kind of consider LVH as a culprit. Yeah, I don't know. Let's find out about the patient. 83-year-old woman, congestive heart failure and heart murmurs, noted since early adulthood. What is a unifying etiology that would account for the rhythm, the precordial voltage, and access here? Note the leads were placed correctly. Oh, okay. Well, heart murmurs since early adulthood, and she's 83, so she's old. So she might have some sort of structural heart disease that was not operated on because of how old she was, and maybe the surgeries didn't exist back then. So she could have some sort of like tricuspid or bicuspid valve, mitral valve regurgitation and stenosis. She could have atrial valve stenosis. She could have like pulmonic valve stenosis. She definitely has AFib, which is more common with structural heart disease, congestive heart failure. To ask him what's the etiology that would account for the rhythm. It doesn't look so abnormal for me to say that like the heart is flipped around, but she could have had, I don't know, she probably doesn't have like tetralogy. She's going to have some diagnosed cardiac condition that they probably didn't fully operate on given her age and these persistent abnormalities. She has AFib, heart failure, structural heart disease, left ventricular hypertrophy, and but whatever her heart condition is, it can't be severe enough to where, because I mean she's alive and she's 83, so she clearly made it, some of the, she made it pretty late in life. I don't know, let's see, I don't even know what to type in there. Let's see what it is. Atrial fibrillation with left ventricular hypertrophy, but right axis deviation. Oh, is that an outflow tract tachycardia? The combination should make you think of biventricular hypertrophy. Oh, yeah. Okay. Rheumatic heart disease. Mitral valve stenosis and aortic valve disease in this case. advanced age does not exclude clinically significant rheumatic heart disease, which is supported by a long history of heart murmurs. Aha. Yeah, right axis deviation with a left ventricular hypertrophy is strange. Right axis deviation can also be due to left posterior fascicular block. We did talk about that. However, this type of hemiblock is not common as an isolated finding. Usually it's seen with a right bundle branch block, which we see a left bundle branch block-ish morphology. And the diagnosis of a left posterior fascicular block requires exclusion of other causes like right axis, like right ventricular hypertrophy. Interesting. Yeah, you know, I always kind of I always forget about the rheumatic heart diseases. She probably had strep, untreated strep when she was a kid, and then just had lived her whole life with it. All right, let's do one more. This is fun. 2 stars, 3 stars. Let's be honorable. Ah, there we go. No cheating allowed. Well, you guys can't go back. Interesting. Okay. All right, does it look normal? No. Is there a P wave? Yeah. There it is. There it is. Very long PR interval, huh? There. Huh. Yeah. They're everywhere. Weird. Okay. QRS doesn't look super wide. The rate, yeah, I don't know. $1, 2, so 300, 150, 175. The gap looks pretty normal. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 times 6. 78. So that's pretty normal. Now let's do the axes. Thumb up, thumb down, left axis deviation. R wave transition down, down, switches, switches, up, up. Yeah, it's slightly delayed around V4. Could this be so? Could this person have some sort of like ventricular hypertrophy? Yeah, probably. So what's abnormal? What stands out? Really small QRS gain here in lead 2 and AVF. So the T wave looks kind of large in comparison. Is that abnormal? I don't know. I don't have enough context to say. If the patient had chest pain, then I would be suspicious of it. Inverted T wave. Flat ST segment. I don't like that. Very long PR interval. I don't know what this notching indicates. Wonder if there's some pacer activity. Maybe. I don't know. Just looks like a long PR interval. Really, really long. Let's see. Two ways look okay here. I don't see any gross ST depression or ST elevation. All looks pretty good. Huh, I don't know. Kind of a weird looking QRS complex here and here. ST depression, I'm sorry, T wave inversion here. A little wonky here. So that's an isolated part of the heart. That's the high lateral section. Looks okay here. The gain is weird. It's like really big here, but then it's small down here. Huh. And then it's really small on lead 2. Really long PR interval. I wonder if this is some sort of like Lyme disease. I don't know what else causes really, really long PR extension other than like Lyme carditis. I don't know. This honestly doesn't look horribly. Like I'm not really persuaded one direction or the other. I just the PR interval is really long, and then there's this weird notching here too. I don't really know what that represents. Okay, we got to look. 66-year-old male. What evidence subtle is there that he has chronic renal failure? Oh, interesting. Huh. Man, these are hard when you don't look at the answers. Chronic renal failure. Well, I suppose there is a little bit of a peaked T wave here and here. There's a really long PR interval. Yeah, maybe this does represent some hyperkalemia. I don't know. Let's just see what it is. I can't even begin to guess. Sinus rhythm, the prolonged PR interval, intraventricular conduction delay. Yeah, we do see this like incomplete left bundle branch block. Left atrial abnormality, probably underlying left ventricular hypertrophy. We did see that. And probably underlying anteroseptal myocardial infarction. Interesting. Why does it say that? Of note is a subtle T wave peaking in V5. Yeah, that is subtle. With a slightly long QT, the former is consistent with hyperkalemia, and the latter is possible hypocalcemia, level not available. Sometimes hyperkalemia produces only subtle T wave peaking without absolutely tall P waves, as is the case here. I have no idea what it's talking about interoceptal MI. Huh. Yeah, I just can't see that. Doesn't, yeah. Interesting. I don't like that one. Let's go off on a good note. So I seem smart. Come on, there we go. There's 4 stars. Like Grand Theft Auto. Whoa. Right away. Does not look normal. P waves. I don't know. Is that a P wave? An inverted retrograde P wave? Tell you what, there's a delta wave though. But only with the PVCs. Interesting. These PVCs almost meet like Scarbosa criteria. Anyways, back on track. Whoa, this is tough. Well, these are obviously all wide. There's different, they appear differently depending on the lead you look at. Oh, wait, no, they don't. They're the same. Axis, I don't really know what lead is. I think this one's normal. So this one's normal. So there's left axis deviation. Normal. Wow, that's a big T wave. Jeepers. Yeah, the RF transition is kind of normal. 1, 2. I don't even know if these are conductings, but let's just count them as beats. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 66 beats a minute, so it's a little slow. Boy, this looks strange. I don't like seeing inverted notching here. That makes me think it's a retrograde P wave with a like a premature junctional or a premature ventricular complex. That little notch right there, that's a P wave in there. P wave. Well, some sort of AV node dissociation is happening. See,
it's an AV node class 1, type 3, subsection F, header 4, rule number 9, moments type 2.
I don't like though that verbiage. It's probably going to say it's like a 3-2 AV conduction, Wakenbach, whatever. But like the point is it doesn't really matter. There is AV node dissociation here. There's bigeminy, ventricular bigeminy, because every single other beat is this wide-looking thing. And there doesn't seem to be P waves in front of here. So there's definitely that's a P wave though. These are all P waves. So, oh wait, but look at that. The PR interval is different. Aha, aha, look at that. The PR interval looks okay here, looks okay here, maybe a little bit prolonged actually, but then it's short. And then it's followed immediately by this other thing. Why does it look like that? Very interesting. If this is a premature junctional complex, why is there a P wave in front of it? It's almost as if there's like this intermittent independent atrial and ventricular activity. Huh. Very strange. Yeah. This might be like maybe not a complete heart block, but like, is this a complete heart block and every single other beat is a fusion beat? Whoa. This is tough. Could it be due to an MI? Oh, but this looks different. Because that's a huge T wave. That one is too. I wonder if this person has like an anterior MI or a septal MI with ventricular bigeminy and AV node dissociation. Huh. Yeah. It looks like there's like independent atrial activity here on every one of these. So these would be capture beats, these ones, because they're capturing. And these ones would be fusion beats. But it looks like there's two P waves almost back to back. That's so strange. All right, we got to look. What is the mechanism of the apparent beat to beat 2-to-1 QRS alternation here? Oh boy. Sinus rhythm with Wolf Parkinson White. I mean, it does look like that's a delta wave or whatever they're called. Sinus rhythm with a 2-to-1 block in the right bundle branch block, left interior fascicle. Whoa, this is hard. Sinus rhythm with ventricular bigeminy. Yeah, it does kind of look like that, but it looks more complicated than that. Sinus rhythm with pericardial effusion, tamponade, and alternation due to swinging heart syndrome. Oh, I don't know. Doesn't really look like that to me. These look like PVCs. I don't think it would be so egregious. Sinus rhythm with junctional bigeminy and an intermittent retrograde P wave. That's the one. I think it's E. I feel like we hit this too much for it to not be. Sinus rhythm with junctional bigeminy and intermittent right bundle branch block aberrancy. The retrograde P waves follow the QRS every other beat. Yes, it does. We talked about that. And then an intermittent right bundle branch block morphology. Yeah, that looks like an intermittent right bundle branch block. Yep. I don't know. Could not be. We could be wrong here. Let's do it. We're wrong. That's okay. I mean, we did say ventricular bigeminy, didn't we? Instead of junctional. Okay. The rhythm is sinus with the ventricular bigeminy in late diastolic premature ventricular complexes that come just after the second sinus P wave. See, that's so interesting. There were two P waves. Oh, I knew it. Gosh darn it, all the heck. I knew it. The PVCs have a right bundle branch block appearance, but it's not a intermittent right bundle branch block per se, or Wolf Parkinson White, which the present pattern simulates. Nor is this an alternation type pattern due to the pericardial effusion or tamponade. Yeah, this just looks way too egregious for that. Where there's usually sinus tachycardia with a 2-to-1 alteration of a narrow, wide, or often low and relatively low QRS complexes. The normally conducted beats here show borderline left axis deviation. Ooh, we forgot the axis. Or no, we didn't. Did we? Yeah, maybe we did. But there is left axis deviation. Late diastolic PVCs bigeminal sequence can simulate a number of alternation type patterns and delineates the differential diagnosis of some of the alteration patterns. Can you think of others? QRS alternation with paroxysmal supraventricular tachycardic rhythms. Note that the apparent retrograde P waves in some leads, like lead V3, yeah, right there, are actually within the QRS complex and are due to the right bundle branch block. The actual sinus P waves come on time with every other one followed immediately by a PVC. Yes, we did see that. Yes, we did. See, it's really close. But it still is, this to this is still all the same interval. Man, we didn't really go out on a bang. That was hard. Okay, thanks for watching. More to come.